Alright, am I audible to all of you? Please acknowledge. I think I'm audible to all of you. Alright guys, so today we are here to talk about INICET Predictor series. I will predict topics and then I will tell you what all MCQs are we expecting. Okay. The first topic which we are predicting for this INICET exam is about fracture healing. Now when I say fracture healing, you will have an MCQ on biological steps of healing, in which the first step is fracture hematoma, the second step is inflammation, the third step is soft callus, the fourth step is hard callus, or what do we call as woven bone. The last step is basically remodeling, which is nothing but conversion of woven bone into lamellar bone. Now, what are we predicting? Like, this is that topic, but what MCQ are we predicting? See, I will not take MCQ and then I will explain. I'm not here to just say out a couple of MCQs, because you know that INICET is not an exam of repeat MCQs, it is an exam of repeat topics. So first thing that will come from this topic, first possibility is that they will ask you the duration. So hematoma is seen within 7 days. Inflammation is seen at the beginning of second week, goes till like third week. Soft callus is seen sharp at third week. Hard callus is seen from 4th to 6th week. Remodeling can occur up to like 2nd to 3rd year as well. So one question can come straight away in the form of duration. Second question that can come is, which is the first visible radiological sign of union? That is soft callus. Which is the first visible clinical sign of fracture union? That is basically the hard callus or the woven bone. So this is one possibility from fracture healing that can come. In any of the previous exams, I'm sure you must have seen that they usually give a question on splints, tractions, implants, instruments, something like that. So as far as a question on splints is concerned, there is quite a possibility that you can have the image, you can have an image where you will see the metacarpals and the fingers extended and something on the dorsum of the forearm pulling them towards themselves, in which you will answer it as dynamic cock-up splint. And it is used for which nerve palsy? Radial nerve palsy, also what we call as wrist drop. Second image, which is quite possible, is that they might ask you about something like this, and then your answer will be, but of course, Thomas splint. Now, after splints, it is possible that they can ask you a question on tractions, although chances are very less. If at all a traction is coming, I give you my word, there are 100% chances of gallows traction used for fracture shaft of femur in children less than 2 years of age. Alright, that is something that you need to remember. Now they can ask you a question on casts, which is very, very highly likely, therefore I am putting a star over here. So if there is anterior superior leg spine, if there is inguinal ligament, if there is pubic tubercle, if this is the patella, this is calf, thigh, this is basically the foot thing. So if they show you something which starts just above the middle of the thigh and finishes just above the malleoli, so this is what is called as cylinder cast, also what is called as tube cast, which we used for fracture patella, so there are quite fair chances of this coming in your exam. Otherwise, they can give you a question on handshake cast, which is basically nothing but Colles fracture, or they can give you a question on glass holding cast, which we use basically for fracture scaphoid. As far as casts are concerned, this is a possibility. Alright, now as far as implants are concerned, then you should know just one thing, that this is fracture of patella. I'm showing in the lateral view. So if they give you an image like this, and if they give you an image like this, or if in AP view, if they give you an image like this, and they give you an image like this, then what are you going to mark this as? You are going to mark this as tension band wiring, which is used for fracture patella, which is used for fracture olecranon. Now, as far as handshake and glass holding is concerned, very simple. In that photograph, if the thumb is covered, if the thumb is free, it is handshake. If the thumb is covered, that is glass holding. Alright. So in implants, what is happening for last couple of years is they are giving TBW. So that is how you can cover after fracture healing. The second thing that you can cover is splints, tractions, casts and implants. After this, the third topic which they are asking most often in INICET is the management protocols. Now, when we talk about management protocols, they can ask you about management protocol of fracture patella. So very simple. If it is a comminuted fracture, no other option except patelectomy. If it is an undisplaced fracture, totally no displacement, although it happens rarely, cylinder cast or tube cast. If it is a displaced fracture, then I'm sure we know it is open reduction internal fixation with TBW. What is TBW? I'm sure everybody knows, tension band wiring. They can also ask you about management protocol for fracture of shaft of humerus. And when they do that, you have to remember that if it is an undisplaced fracture, which usually it is not, then U-slab or hanging cast. If it is a displaced fracture, then you have to see that is there radial nerve palsy or without radial nerve palsy. If it is not having any radial nerve palsy, then you have to do open reduction internal fixation with plating. If it is with radial nerve palsy, then also same you have to do. Plus you have to apply cock-up splint for the nerve. If they ask you about management protocol of fracture neck of femur, age less than 60, internal fixation with screws. Age more than 60, if osteoarthritis of hip is there, then we will go with total hip replacement. If there is no osteoarthritis of hip, we will go for hemiarthroplasty. Alright, so these are some of the management protocols which they are asking very often these days. Done. Now, I'm sure with the virtue of the knowledge of the previous year papers, you must have seen that they are asking a question which is usually an image-based question, which is either on GCT or ABC or osteosarcoma or Ewing sarcoma or SBC. Now, if they will ask you a question on GCT, very simple. you will get an image of the distal femur like this. You will get something which is involving epiphysiometaphyseal area. You will get a single air-filled sinusoid called as soap bubble appearance, and most importantly, you will not see any growth plate in this because the age group is 20 to 40 years. Okay. Same thing you can see in the distal end of radius also. That's absolutely fine. Now, if they will give you an ABC, they can give you proximal tibia, they can give you distal radius. So let's say if they give you distal end of radius, they will be in the metaphyseal area where they will show you this, but that doesn't matter. What matters is that they will show you what? Physis. And then you will have these blood-filled sinusoids. As far as osteosarcoma is concerned, I'm sure everybody knows here that there is no problem at all, that you will see periosteal reaction along the Sharpie's fiber, which is what is called as sun ray or sunburst appearance. Or you will see a periosteal elevation like this, and this periosteal elevation like this will be what will be called as Codeman's triangle. Then you might have an Ewing sarcoma in which you will see laminated, layered periosteal reaction along the shaft. That is what is called as onion skin or onion peel appearance. Okay, done. Then you might have a condition where they will mention proximal humerus, they will mention 4 to 10 years age group, they will mention metaphyseal area involved, they will mention asymptomatic, they will mention pathological fracture, and they will mention fallen leaf sign. All these things will take you towards the diagnosis of SBC. Now, after these image-based questions, usually you can find an image-based question, and that image-based question will be on the fractures. Now, as far as fractures are concerned, I give you my word that either it will be Montegia, or it will be Galeazzi, or it will be Colles, maximum to maximum Smith, Barton, Schoeffer. Most likely. Now, if you will have a radius like this in the image-based question, if you have an ulna like this, then I'm sure you all will agree with me that fracture of proximal 1/3 of ulnar shaft with dislocation of radial head, that will be called as Montegia. Alright? You understand? Fracture of proximal 1/3 of ulnar shaft with dislocation of radial head, that will be called as Montegia. Fracture of shaft of radius at the junction of middle and distal 1/3 with this DRUJ dislocation, that is what is called as, yes everyone, that is what is called as Galeazzi. Alright. If you have a proximal fragment like this, and if you have a distal fragment like this, and if you have the 8 carpal bones like this, and if you have the 5 metacarpal bones like this, this is basically what you call as Colles fracture. Alright, now if you have a proximal fragment like this, if you have a distal fragment like this, and if you have the 8 carpal bones and the 5 metacarpal bones, then obviously you will see a volar displacement of the distal fragment. So this will be what will be called as Smith fracture. I hope you understand. Now, if on an AP view you have a fracture like this with distal end of radius extending into the wrist joint with radial stelloid bony fragment, that will be called as, on an AP view, Schoeffer's fracture. But on the lateral view, if you have a fracture like this where you see a radioscaphoid joint subluxation, then it will be called as Barton's fracture. Alright, so this will be Barton's fracture, while this will be Schoeffer's fracture. Alright, this will be called as Schoeffer's fracture. So these are the topics which they are repeating every now and then. Now, one more thing which they are repeating now and then is basically a clinical test. Now, as far as a clinical test is concerned, they can give you a question on, knee ligament injuries. Now, everybody knows that in knee ligament injuries, they can ask you anterior drawer test, or they can give you a Latchman's test. Alright? Very basic. They can give you anterior drawer, they can give you Latchman. Otherwise, they can give you tests for carpal tunnel syndrome, Fallon's, Durkin's, Tinel's. Alright? Or what they can do is they can give you the test for the various tests like book test, what we call as the Froment sign, card test, Igawa's test, pen test, something like this. And if there is any confusion that you people are finding in identifying any of the clinical tests, please feel free to go to my YouTube channel. Over there I have described almost every single individual test. Okay, I have described all these tests which I've mentioned here, they all are described individually in different videos. Okay, and not only that, I've described all these eponymous fractures as well. Another pattern of question that we see often is basically from applied anatomy. Now, when we talk about applied anatomy, that is usually what we are talking about is median nerve in hand, or what we are talking about is intrinsic muscles of the hand. The 20 intrinsic muscles, the 4 thenar, 4 hypothenar, 4 palmar introtia, 4 dorsal introtia, 4 lumbrical, and how median nerve is divided into lateral division, medial division, what is sensory, what is motor. So that is something which I predict always, that applied anatomy, this part is very, very important. One question is undoubtedly, there is no confusion, is going to come from infections. So what they can ask you in infection is, they can give you the photograph of a bone. They will show you a central dead necrotic ischemic excessively white piece of bone which we call as sequestrum. So they will put up an arrow like this. They will surround it with something which I'm sure by now you must have understood, the periosteal reaction, that is called involucrum, with certain holes called cloacae. So that is one possibility. The second possibility after this is that they put up a very simple straightaway question that in management of septic arthritis, the investigation of choice or the next step is MRI or USG. You can do both of them sequentially, but the best step, if they ask you, is basically arthrotomy, that you drain the entire joint out. Right, you drain the entire joint out. Now, one question usually comes from pediatric orthopedics, which can be on CTV shoes, which is not a property of CTV shoes. Everybody knows in a CTV shoe you have to have a straight inner border, you have to have a outer shoe race, you have to not have a heel. Second, they can put up a question on this topic called as Klippel-Feil syndrome. So in the triad of Klippel-Feil syndrome, you have a short neck, you have decreased mobility at neck, you have low posterior hairline. Usually the question comes that what is a part of Klippel-Feil syndrome but not a part of the triad? The answer is short stature does not form triad. Then you get a question like this, that there is a 7-year-old boy who has pain in the hip, who cannot squat and who cannot sit cross-legged. Okay, who cannot squat, who cannot sit cross-legged. So tell me the answer. The answer is very simple, Perthes disease. So that is what I'm trying to tell you, that all these things can be possibly asked to you. There are multiple other topics, but these are the 3 topics that we see often: Perthes, CTV and Klippel field. Of course, they can ask you any other thing. The last topic of prediction that I want to share with all of you here is something related to supracondylar fracture humerus. Not only supracondylar fracture humerus, but related to its complications. Say, for example, they can give you an image-based question in which that image-based question will have just a girl standing in front of you with her arm like this, with her forearm like this, and they will ask you to identify the deformity. You will say cubitus varus or gunstock deformity. Maybe they can ask you that which is the last P to develop in compartment syndrome, and you will say it is paralysis. Okay, they can ask you that in myositis ossificans, which is the most common muscle involved, and your answer will be brachialis. Something related to the complication. They might ask you which is the most common nerve injury, and your answer will be anterior interosseous nerve, which is a motor branch of median nerve. Or in a very, very simple language, they will ask you that which is the most common displacement that we see in this fracture, and your answer should be posteromedial. The last set of prediction is probably an angle, probably a line, probably a classification. We'll take it one by one. In angles, I think you should know that Cobb's angle is used in scoliosis. In line, I think you should always know about Shenton's arc in the X-ray of hip joint. As far as classification is concerned, you should know that Hawkins classification is used in fracture neck of talus. Neer's classification is used in fracture proximal humerus. Bedou's classification is used in Montigia's fracture. So this is my prediction. We all are aware of this fact that we will not get 11 MCQs from orthopedics, but I have predicted again that this exam is not an exam of repeat MCQs, it is an exam of repeat topics. So I wanted to, in half an hour, I wanted to cover not only those topics out of which MCQs can be asked, but I wanted to give you a gist of them as well. So this is probably the most concise prediction, where not only we have done some 10-12 random MCQs, but we have understood that what all topics we need to focus on in 2 hours, 3 hours that we have allocated, maybe tomorrow, day after tomorrow, or maybe tonight itself for the revision. Done? Alright guys, I wish you all the best. God bless, do well, study well, work hard. And if there's anything apart from this that you want me to tell you, feel free to put it up, and you can message me on my Instagram as well. I will try to help you as much as I can before your exam. So dr_Tushar_Mehta on Instagram, and I shall come up with a video for the same. If you have any problem with any topic, or you can go to the YouTube channel, it is again by my same name, and you can find detailed videos on certain eponymous fractures, certain clinical tests.